any questions or comments at this during this entire show, feel free to leave them below. And we're with Dr. Joseph DiRocco at GBMC. How are you?
Hi, I'm doing well. Good morning, Greg.
We kind of have a sensitive topic today, and I'm going to sort of approach you as a patient where I'm actually a little nervous to talk about things, but we're really talking about bowel incontinence today, aren't we?
Right.
Should I be nervous as a patient to come to you?
Well, I mean, whether you should be or not, typically people are.
Yeah.
And that's part of the reason why I wanted to talk about this today, because it is, as you mentioned, a very sensitive topic. People don't like to talk about it. They keep it very private. They don't want anybody to know, and that's part of the problem of bowel incontinence is the fact that people are very reluctant to look for help. And a lot of times they don't even know that there is help out there.
Yeah, interesting, no kidding. How many times have you had a patient come to you and say, look, I think I have a problem, but I didn't want to come to you, I've been nervous, do I have a problem? I guess really explain what bowel incontinence is for somebody who's wondering.
Certainly, and virtually all of my patients feel that way.
Yeah.
So bowel incontinence or fecal incontinence is the leakage of stool or gas. Sometimes people have leakage of only loose stools, like typically associated with diarrhea. Sometimes people have what we call full incontinence to feces, which is passing stool without any awareness, or there's another possibility of having people with urgency where they feel like they have to go to the bathroom and it's an emergency every time and sometimes they don't make it. There's a lot of different types of bowel incontinence.
How do you separate, and this again, I feel kind of strange asking the questions because, is it comfortable, is it not comfortable? But how do you know whether it's something real or I just had something bad to eat last night for dinner?
Right. So typically people who've had an isolated episode, and it's not uncommon that people have, say, a viral illness or some form of infection or exacerbation of pre-existing intestinal disorder, where they have an increased frequency of loose stools and end up having some degree of incontinence. Now, those things, we typically address the underlying issue. And if somebody has a one-off episode, that's not really something that needs to be addressed, although if it's a chronic problem, something that recurs over and over again, that's something that needs to be addressed.
What do you consider chronic? Is it a week? Is it a month? Is it, oh man, I needed somebody because it's been, because it's been 6 months? Right.
Yeah, no, I hear you. So, I mean, the issue is, it's not an inherently dangerous condition. So, the problem with it is that people have to adjust their lifestyles. Some people become recluse because they're afraid to go out because they never know when they're going to have an episode. They don't have the confidence. Other people shape their entire lives around an internal map of bathrooms. So, they may not be restricted in terms of their traveling because they say, well, I don't know if there's a bathroom there. Sometimes people have to bring extra pairs of clothes. They have to wear adult diapers. There's a variety of different things that people do to compensate for their problem and adjust their life around it. And in some cases, it can be quite limiting.
So if you're changing your routine, you really should look into it.
Yeah, absolutely.
Yeah.
And also, sometimes from chronic leakage, even if it's not a lot, it can be very irritating to the skin around there. It can develop a lot of itching and irritation. There's a variety of reasons why somebody would seek help for this problem.
And we're strictly talking bowel. This has nothing to do with bladder. For you as a doctor, is that something completely separate or are they related?
So, the reasons which lead to bowel incontinence, sometimes there's a significant overlap with bladder incontinence. And while I don't personally treat bladder incontinence, it's not atypical for patients to have both conditions occurring simultaneously.
Interesting. So a patient overcomes their nervousness, they come to see you. How do you diagnose what you see and then what happens with treatment once you realize something's happening?
Right. So even though people are very reluctant to undergo evaluation for this problem, and a lot of the time it's because they don't realize that there's help available or they think that the solutions are drastic, we take a very scientific and regimented approach to addressing this. So the first part is, and it's likely the most important part, is just a detailed history, going over when do you have episodes, what's your bowel function like, what medications are you on, have you had any.
Can family history play a part or no? Is it pretty individual?
It's fairly individual. There are some conditions which run in families which may interact, but typically it's dealing with the individual. And while it's very common in older people, so about 1 out of 8 people over the age of 70 will have some degree of bowel incontinence.
What was that number again?
Yeah, so somewhere
1 in 8?
1 in 8, so
Wow.
somewhere around 15%.
Okay.
How many of those people? And this is non-institutionalized people.
Sure.
This is not just people in a nursing home. This is people trying to live their lives.
Yeah.
So it's quite a common condition, and part of the reason for having this conversation is, to open up the dialogue. And I think that's the biggest factor in people not getting help.
Yeah, and
is reluctance.
And talk about opening up the dialogue. Feel free. I know you might have some reservations, but if you have a comment or a question, which might even be more important, feel free to leave that comment or question below, and we'll get it addressed on our Facebook Live with Dr. DiRocco of GBMC. As far as, again, patients coming in and coming to see you, how do you make them feel better, or not better, but comfortable with the experience?
Right. So, certainly having a light but professional attitude helps. Some jokes, getting to know the person a little bit, asking about some of their background and what their experience is like, and letting them know that this is not an uncommon problem and that that there's help available.
And it really helps when you get a relationship with your doctor. You're like, all right, I can trust this guy. He makes me feel good about what's going on. And the patient-doctor relationship is so important.
Yeah, and it's important for me too.
Yeah.
Because that's what makes my job fulfilling.
Yeah. Yeah. Now, typical warning signs. Again, I guess we can go back to it a little bit. Did I have something bad to eat last night, or is this something real? Are there warning signs other than I had diarrhea last night?
Right. So typically, this is not something that occurs all of a sudden. It's a gradual progression. So, there's not really warning signs because you only are going to seek help once it becomes a big enough issue where it's negatively impacting your life to the point where you overcome your anxiety about.
That's what I was going to say.
Reaching out.
I guess again, once you change your lifestyle, there's your warning sign. Right. I would think.
And and I would think as well. But there is a significant reluctance to talking about the problem in general, and then undergoing an evaluation for it and possible treatments.
How often do you see things, one symptom leading to another, to a serious problem, and then also, all right, well, maybe does it relate to cancer at all? Like, can things get really serious?
So one of the signs of cancer is a change in continence. That's a fairly atypical presenting symptom for colorectal cancer or anal cancer, but it is something that can occur. So if you do have some form of acute change, and acute by like a rapid change, that seems to be persistent, certainly, evaluation would be warranted.
Sure. And as far as treatment is concerned, you see these over-the-counter products. I don't even really know any. I guess Imodium is something. Is that your beginning step? And then does it lead to surgery? Like, how do things get fixed?
Right. So, as I said, the first part is a detailed evaluation, taking a good history, doing a detailed physical examination, and there are some other testing which we do on occasion to measure anal strength, reflexes, nerve sensation, to try to pin down exactly where the problem is. The majority of people can be improved with just lifestyle modification and some medications, and so the standard therapy that we do, for the most part, is a combination of what we call bulk forming agents, so fiber, and a lot of people are very reluctant when you say, well, I'm recommending to increase your fiber, because they look on the package and it says fiber laxative, and they're like, that's not what I need,
Right.
But it's a combination of both the fiber to bulk up the stools, so that way your body it's easier to detect when it's going through and easier for it to control, and then to slow things down a little bit, something like Imodium, and then there are other prescription antidiarrheal medications as well to slow things down so you have more formation of the stool and possibly more warning time. Yeah,
I've heard, and again, not from doctors, but I've heard people say don't do Imodium because that messes your whole system up. Is there truth behind that or no?
So for some people with an infection, so infectious colitis, taking Imodium and antidiarrheal medications, and it's only a limited number of types of infections in which this can occur, but with the Imodium, by slowing everything down, especially if the infection is causing release of toxins and things like that, those toxins will remain in the colon. The idea is it can worsen the infection.
Interesting. Okay. Now, since we're sort of in that area, does a bowel incontinence lead to hemorrhoids? Are hemorrhoids part of it, or are they two totally separate situations?
No, so incontinence typically doesn't lead to hemorrhoids, but certainly part of the evaluation is to assess the size and nature of the patient's hemorrhoids, because especially in younger people, from enlarged internal hemorrhoids, and hemorrhoids are just blood vessels under the skin, but sometimes they can get so enlarged, either from chronic straining or just genetics, that they can start to protrude. And if they protrude, they can break the seal and cause some degree of leakage. So,
when you say break the seal, what's the seal?
like the anal muscle, the anal canal. So the anus.
So it's almost like a hernia, sort of. I'm
Similar.
making that up. Yeah.
I don't know. So the idea is that there's an expression that the anus is the most complicated muscle in your body, because the idea is that you can basically allow gas to pass without material, and if you had material in your hands, you can't open your hands and allow just the air to go through without having everything drop on the ground. But the anus can do that.
How does it know?
Well,
anyway, that's probably another subject, I guess.
So the anal muscle is definitely like the key component here in terms of controlling stool and detecting that it's there. And so by having enlarged hemorrhoids, I can break the seal and can lead to leakage and discharge. And so a lot of the times when people have enlarged hemorrhoids, so we can do something simple even in the office, like rubber band ligation or hemorrhoid banding to shrink.
I don't know what that is, yeah.
Yeah, so like I said, it's a procedure we do in the office.
Sure.
It doesn't require anesthesia. It literally takes less than a minute to do. And so for people with enlarged internal hemorrhoids that are not terribly enlarged, we can do this procedure, and typically people have about a day and a half of discomfort afterwards. Usually doesn't require medicine, and by doing that and shrinking down the hemorrhoids, a lot of the times that can solve their problem.
Sure. If they're really enlarged, is that surgery?
Typically.
Yeah.
How
do you know whether you have just irritation or you have hemorrhoids and it should be looked at? Almost kind of like the same with bowel incontinence. We went from step 1 to step 2. How about that with hemorrhoids?
Yeah, so a lot of the symptoms of hemorrhoids can also be symptoms of colorectal cancer, and so take those symptoms more seriously. So things like bleeding, anorectal pain, et cetera. So those things definitely need to be evaluated.
I have a Facebook viewer that has sent a previous question, and it says, I have suffered with IBS for some time now. There are days that I feel like I'm not going to make it to the bathroom and have had some leakage a few times. I'd like to know what can be done to help with this.
Right. So again, that's describing more of this urge incontinence, where you have that severe urgency, and hopefully you make it most of the time. Sometimes you don't. Oftentimes that can be just as distressing, if not more so, than just regular incontinence, where there's an absence of awareness that you pass stool. So there's a number of people who just they go to the bathroom to urinate and they realize that they've passed stool, or they start to smell things, or there's a variety of different ways that can come into into awareness. So for people with IBS, the issue is that they have a lot of, spasm and cramping of the colon, among other things, and addressing the underlying condition, like the IBS, is typically helpful. There may be other components to it that can be addressed, and that's why an evaluation by somebody like a colorectal surgeon, such as myself or Dr. Apostolides or Grasso at GBMC, and can certainly do that.
It's almost like if you think you have an issue, just reach out. Just don't worry about the embarrassment. And you talk about undergarments and so forth. Going to the store and making that purchase. Take care of business. Don't worry about the embarrassment. Just seek whatever help you need to have. Yeah.
Absolutely. Yeah. I mean, fear and anxiety are are major impediments to people's health.
Yeah, really. And I noticed that with myself with other things. It's like, I don't want to get that checked out. I'll just work myself through it. It's fine, whatever it might be. But really, I probably should go see somebody. And the weird thing is, we talked about this several months ago in our Facebook Live with GBMC. We talked about hearing. And I was like, my ears ring, but I'm fine, doesn't matter. Well, my ears ring. I probably should do something about it. And this is the same situation here.
Right.
I think you may have answered this before, but I just want to make sure we really get it clear. Is there age discrimination with bowel incontinence? Is it usually older people? Can anybody have an issue?
Well, anybody can have an issue, but certainly the longer you live, the more likely you are to develop bowel incontinence.
Is there a way to prevent it? This is probably something different, but you hear of the Kegel exercises or whatever. Is that the same thing? Is that something we can do?
Yeah, so a Kegel
Explain
exercise.
what they are.
Yeah, so it's basically, and I'm doing it right now.
Oh, right here?
So,
Well, maybe I should try.
Yeah, you should. We can do it together.
I'm good.
So what it is just a maneuver where you tighten up the anus or the pelvic floor, and the way I try to describe the patients is try to pull your anus up to your chin. Okay, so
why did my chin go up? Yeah, it's true though. That's how you do it, and that will strengthen things.
Right, and so it's you can do anything else while you're doing these maneuvers, and typically recommend people to do it on a regular basis. There is some suggestion that might strengthen the pelvic floor muscles over time, and as you mentioned, it's the same maneuver for bowel incontinence as for some forms of urinary incontinence, and sometimes people benefit from doing something like pelvic floor physiotherapy. So it's, there's a lot of different kinds of physical therapy out there, but there are specific physical therapists that have training and expertise in doing pelvic floor physical therapy. So that's often one of the recommendations we make for people is to go over, and actually at GBMC we have a pelvic floor physical therapy program.
Interesting. Okay. When you think about it, though, it seems natural. A biceps needs exercise. This is just another part of the body that needs an exercise.
Right.
Yeah.
And and the muscle is certainly one important component to it.
Yeah.
And you mentioned are there things that can develop over time? A lot of the reason why people have bowel incontinence, it's not just because they have some loose stools, but there can be either nerve-related or muscle-related problems down in that area. Mm-hmm. And so, people at high risk are people who have had childbirth trauma, trauma from surgeons.
Yeah. Do you find a higher percentage of male to female, or is it pretty 50-50?
No, it's so it depends on the age group.
Sure.
But certainly there's a higher percentage, at least, of patients in my practice that are female, just because, again, their muscle mass may be a little lower, and over time their muscle mass decreases, and so their ability to compensate, starts to fade.
Makes sense.
And secondly, they're at risk for, childbirth injury or obstetric trauma.
Right. For the bowel incontinence, we've talked about all of these things you can do to prevent and also maintain. Is it always going to be lifestyle maintaining, or can it actually be corrected?
Yeah, so it can be corrected.
Yeah.
So the first thing we do is try to develop a good bowel regimen to try to get the best quality stool, down to that area so your body can deal with it. And I would say the majority of patients improve just with simple suggestions and some changes in their medications.
Yeah.
Beyond that,
diet's included as well, right?
Diet is included in that as well, correct. Beyond that, there are surgical procedures. I'm a surgeon, so of course there's surgical procedures involved. The most long-standing corrective procedure is where we actually repair and overlap the muscle. Can be a difficult procedure to get through. Because
recovery, I would think, would take a long time.
Yeah. And and then the other problem with that is sometimes the benefit of that surgery fades over time, and so unfortunately about half of people who have that will be back to where they were within 5 years. So that doesn't sound too great, does it?
Yeah. Interesting.
So there is something else, and I don't know if you wanted to ask another question, but I can.
No, keep going.
Yeah.
We're good.
So the most exciting thing in this field is approval of something called sacral nerve stimulation or sacral neuromodulation.
Okay.
But there's a device, like an implant, like a pacemaker, that can be put, and it's directed towards the nerves that go right down to the pelvis.
No kidding.
And so we do a trial period where we, before we implant this thing, we put some wires in and have people connected and go for a week or sometimes 2 weeks to test left side versus right side and see if they have an improvement in their episodes.
Yeah.
And if they do, then we go ahead and do this implantation of this device. And it's been around for urinary incontinence for about 20 years.
No kidding.
It was only FDA approved for bowel incontinence, I think about 7 or 8 years ago.
Yeah.
I think in 2011.
That's interesting. Yeah, do you find that this is really a last resort, or is something like this like, all right, you know what, let's go ahead and try this before we get to
So
the
I
last
mean,
resort?
for some patients, they feel like this really is the last resort because you know, as uncomfortable it is talking about this problem, the idea of doing some form of nerve stimulator is really off-putting and terrifying. You know,
it's interesting because as I sit here listening, now I'm not involved,
right?
But as I sit here listening to it, I'm like, all right, well, that might be a real good quick fix.
And I think it is. I mean, and people have a significant improvement. And honestly, out of all the things that I do, like out of all the procedures, I mean, it's one of the safest things that I do. It's one of the least stressful things that I do. And it really helps a lot of people. And so the results with that device, the sacral nerve stimulator, about 87% of people have at least a reduction of half of their episodes, even beyond a year. And about 40% of people have complete resolution of their incontinence with this.
Isn't that something?
And it requires very little to no maintenance. So there's a battery in there, so it has to be changed right now every 5 years. I mean, right now I can put my phone on a charger and not have anything. So I would imagine the next generation will have wireless charging.
Have an easier way to recharge.
Have a charger right on the toilet.
And right, that'd be interesting. But to me, to have that stimulator, I'm not sure what that means, but okay. Sorry about that. To have that stimulator as an option instead of getting in there surgically and manipulating muscles just seems like the best thing to do.
Yeah, I mean, there's very little pain involved. There's very little in the way of complications, and we don't mess around anywhere near the bottom. Where the wires go in is just in the lower back portion called the sacrum. And wires go right in where the nerves are. We put them in under x-ray guidance in the operating room, so they're in exactly the right place. Everything's tested ahead of time, so we know you're going to have some improvement with it even before we go and put it in. So to me, that's a no-brainer. And it's really changed our treatment strategy for dealing with this problem because it's so effective. And a lot of times you say, well, some people have a nerve problem, some people have a muscle problem. Who's going to benefit from this nerve stimulator? Some people have IBS, some people have it. And the reality is there's no predictors of whether or not this is going to work. We just try it, and it works most of the time. I mean, I have very few people that don't go on to have the implantation once they have that test and they see the results.
Yeah, that's great. Again, always encouraging your comments. Just leave right below us. That's what the benefit of Facebook Live is, that if you have a question or even a comment, feel free to leave us those comments as we are here with Dr. Joseph DiRocco at GBMC doing our Facebook Live about incontinence and also hemorrhoids, talking hemorrhoids. As far as that stimulator is concerned, there's nothing like that for hemorrhoids. It's either let's take care of business. We're either going to solve it easily or through surgery, right?
Right, and there are, there are about 10 different operations, and maybe I'm exaggerating, but I can at least think of 7 different types of operations to do for hemorrhoids. So, everybody lumps any problem in that area, if you're having bleeding, pain, discomfort, everybody says hemorrhoids, and so when people come into the office with a, diagnosis, they say, well, I'm here for hemorrhoids. Only about half the time is it actually hemorrhoids going on. There are other things that can happen in that area.
Sure.
So first thing we need to do is get the proper diagnosis, and then, like I mentioned, rubber band ligation, which is something we do in the office. That's relatively simple and easy, and then there's a variety of other things we do to try to decrease the pain and speed up the recovery after hemorrhoid surgery. In some cases we still have to do that conventional hemorrhoidectomy where we remove all the hemorrhoids. The good thing about GBMC is that we have a numbing medicine called Exparel, which can last for up to 3 days, and that's helped a lot decrease pain after hemorrhoid surgery.
Oh, interesting, I've learned so much today. You didn't realize it was as involved as it is, but of course it is because it's a specialty of yours. As far as the next steps for people, because people watching will say, all right, well, maybe I have this issue. What should they do to get their treatment? How do they start off with you?
I mean, the easiest way is just to call and make an appointment.
Yep. And the number, if you're interested, is 410-296 1661, right?
That's right.
Yeah. How do I know that?
Right. Or they can just go through the gbmc.org website.
Oh, it makes it simple. Right. Excellent. So they come in, they see you, and then a complete thorough examination and a good relationship with their doctor starts.
Yeah, and honestly, that's the real benefit of working with people with this, is that you get to know them and figure out what's going to help them, what's not. I mean, because ultimately, for bowel incontinence, this is not a life-saving intervention. This is really 100% about quality of life.
Yeah, sure is. And don't feel embarrassed to start talking about things with your doctor and get things rolling if you want to. Again, 410-296-1661 or gbmc.org/GI-oncology. You've been great. Really appreciate meeting you today and talking about all this.
Yeah, pleasure's all mine.
It's so funny. When we first start this, I had the same thing as a patient would be. I'd be like, we're talking about bowel incontinence and hemorrhoids. But now we're I don't know what time it is, 20, 25, 30 minutes later, and I feel completely at ease. And that's a testament to you.
Yeah, and I was very nervous being interviewed, and now I'm very relaxed, and that's a testament to you.
What? Did you hear all that? So our next Facebook Live, it's going to be here in the Performance Studio. It's April 4th. We're going to be discussing oral cavity lesions. So we would love to see you then. Thank you for joining us today. GBMC's Facebook Live with Entercom Radio and today's 101.9.